Okay, this is a really cool 9-week-old supraventricular tachycardia case that I wanted to share. So this was a 9-week-old. He presented with a rapid heart rate. His history included fetal SVT as well as Wolff Parkinson White or WPW, diagnosed in the neonatal period. His mother basically said she was breastfeeding him. He was fine, and she just noticed a high heart rate. She says that he has not had any trouble breathing or sweating or any evidence of being ill or having a fever. He's breastfeeding well before and after, no concerns there. And when he was in the hospital as a newborn, the pediatric cardiologist started him on sotalol 6 milligrams 3 times a day. In the emergency department, he's noted to have a normal temperature. Heart rate is 240, and just for reference, normal for a 9-week-old is 160 is the max. Blood pressure, respiratory rate 30 breaths per minute, which is okay in a 9-week-old. O2 sat okay. Weight was okay at roughly 11 pounds. He was well nourished, well hydrated, and no distress. HENT exam was normal. He was noted to be tachycardic with no murmurs, rubs, or gallops. The rate was regular, and he had good central pulses. Lungs were clear, abdomen was soft, extremities were acyanotic with a brisk capillary refill, and there was no edema noted in the extremities. Skin was warm and pink, and the neuroexam was non-focal for a 9-week-old. So here's this child's first EKG in the emergency department. And what you can see here is this is obviously a very rapid heart rate. It's hard to count out on this computer screen, but essentially this one box would be from this tiny little box here to the next tiny little box would be 300, and to go to the next one would be 150. So in between there is around 225 would be the guess between those two. The rhythm is fairly regular, right? The QRS complexes across the bottom here do not appear to be variable or oscillating in any way. You do see some inverted T waves in V1, 2, and 3, which can be normal in pediatrics and also incidentally in WPW. And then what maybe perhaps most importantly, you don't really see any P waves anywhere in any of these leads, not that I can see when I looked at this before. So this is what SVT looks like electrocardiographically. So let's just talk about SVT briefly. Just thinking about the terminology here, supraventricular, right? So you're above the ventricles. That's what tachycardia problem is. Supraventricular tachycardia, very common, relatively speaking, is a symptomatic arrhythmia in infants and children, especially in the first few months of life, and typically presents with a rapid heart rate exceeding 220 beats per minute. As the kids get older, that SVT heart rate will sort of trend down, and by the time you're in adulthood, in adults, you're seeing around 150 or 160. Here's an illustration of what SVT looks like. Okay, basically you have this circuit here that is just doesn't break spontaneously and requires medications. It's obviously a problem if it goes untreated, but this accessory pathway that's noted here is essentially feeding right back into the AV node and into the ventricles here. Okay, but the problem is above the vents, right? So you have this circuit that's running, this wheel that is spinning, and the accessory pathway is actually, bypassing the ventricles, which is why you have a narrow QRS complex. Okay, and there are different ways this pathway can manifest. This is just an illustration of sort of a conceptual way to think of it, but of course, there's half a dozen ways that the accessory pathway can exist. So EKG findings, essentially think of narrow complex tachycardia without a P wave. You can have retrograde P waves with some of those other abnormal accessory pathways, which can cause an abnormal axis as well. QRS is typically normal, but again, can be aberrant. And then the key feature here in SVT typically is it's kind of a fixed heart rate, right? There's no variability. And this kid stayed right at 220. Here's a little bit of a table or a way to think about tachyarrhythmias, right? There's ventricular tachyarrhythmias, which are not sort of discussed here, reviewed, different beasts altogether. And then the supraventricular ones, which can be broken down into atrial and AV nodal, right? The atrial tachycardia is AFib, most common in adults. Well, actually, atrial tachycardia probably. And then, or sinus tachycardia, I should say, not atrial tachycardia, it's different. And then atrial flutter is also seen. And then you get in the AV nodal junctional tachycardias, right, which is what we're talking about with SVT. You can have nodal reentry tachycardias and then accessory pathway tachycardias, which is just a different way of characterizing where that abnormal pathway is, right? And then there's rare and common, and then there's over here, I'm not really sure what they mean by CT. But basically, these are the different ways that feed into the paroxysmal SVT, right? There's a bunch of common pathways that get us to SVT. Okay. Etiology, about half are idiopathic, and it's not like there's not a reason for it. We just don't have that. We have blunt instruments. We cannot identify this accessory pathway. We just don't have the tools that are sensitive enough to find these smaller pathways. Okay. However, about a quarter of kids will have some kind of infection or fever or drugs, congenital heart disease, and WPW is the case with our patient. Typically, you don't know if there's an underlying rhythm dysfunction until the patient is returned to a sinus rhythm, right? When you're going at 220 or 240, you really can't interpret the EKG in any meaningful way. This is what WPW looks like on an EKG. And essentially what you're seeing is a broad QRS complex with a slurred upstroke. So if you go to V3 here, I'm just kind of arbitrarily picking V3. You can see the start of the R wave here is very slurred. It's called delta wave, okay? You can have a dominant R wave in V1, and then you can have flipped T waves in V1, 2, and 3 as well, which again can be physiologic in children, but is also classically seen with this flavor of WPW. How do they present? Well, infants are typically non-specific, right? They cannot tell you they feel ill, but they may be fussy and they might not be feeling well. They may look unwell or lethargic. As they get older, they'll say they have chest pain or lightheadedness, palpitation, shortness of breath. They may feel like they're going to pass out or they may have passed out. When they check in, the heart rate is universally noted to be elevated. You may hear the phrase too fast to count. Of course, now we have monitors and we'll get an accurate heart rate, but when you do a radial pulse, it's just insanely fast. If the patient has some evidence of heart failure, they may be ill appearing, right? And again, in neonates, that's pallor, coughing, extremis. And infants can tolerate SVT for 24 hours, but after that, you're high risk of decompensation and heart failure. So it's very important to get them in front of an ER doctor and a pediatric cardiologist. Management, of course, always starts with the ABCs in any of these patients, right? You have to manage their airway first if they're decompensating. If they're unstable, right? And how do we define unstable? Well, in infants, that'd be abnormal vitals. They always have an abnormal heart rate, but their blood pressure is undetectable low. They have evidence of heart failure, poor perfusion, right? And so if you can try vagal maneuvers first. However, in general, you're going to go to cardioversion, right? So you try the vagal maneuver, while you're setting up for cardioversion. Essentially, if it works, great. If it doesn't work, well, now you're moving down to cardioversion, right? So synchronized cardioversion here at 1 joule per kg, and then you can bump it up to 2 joules per kg. And you may try this a couple times. You should plan on sedating them. I don't have the sedating meds on this slide. And then, of course, if they are not unstable, right, no shock is present, you're going to do the vagal maneuvers. And how you do that in a kid is basically an ice cloth or cold cloth over the forehead without, don't burn them, don't cover their eyes up and damage their eyes. If vagal maneuvers don't work, adenosine, right? And adenosine in pediatrics is dosed at 0.1 mg per kg or 100 micrograms per kg. And you can double that. And then in this version, you see it even tripled, right? So you can go up to 18 milligrams would be the max at 0.3 mg per kg you see here. Okay, and remember, this is metabolized very quickly. You have to have a Y flush and slam in some normal saline after you push the adenosine to make sure it gets to the heart before the body metabolizes it. You can also consider other drugs, right? Amiodarone is listed, procainamide, beta blockers. This is going to be in consultation with a pediatric cardiologist. You need to avoid digoxin and calcium channel blockers. They've been shown to cause cardiovascular decompensation in neonates. And then, of course, cardiology, okay? The good news is prognostically is most of these infants outgrow SVT, and up to 90% are in complete remission by 12 months, right? So you just basically outgrow it, which is fantastic. So in the case of our patient, we confirmed that he had paroxysmal SVT with that first EKG. He was converted to a normal sinus rhythm after an ice bag on the face. This is his EKG. It's harder to see because it's not zoomed in, but essentially you don't see that slurred upstroke that you saw before. You do see the flip T waves here. This is a more subtle version of WPW than the white EKG I showed a few slides before. Cardiology saw him. They said, let's leave his sotalol alone and do nothing. He went home, but he got home and had another episode, so mom brought him back. In this case, he was admitted to the hospital. It's his second presentation. He did well overnight, and then they increased his sotalol to 7 milligrams from 6 and went home sort of in good condition. Okay, so 3 key points about neonatal SVT. It's the most common symptomatic arrhythmia in the first few months of life, with a fixed heart rate often exceeding 220 beats per minute. The EKG is the diagnostic gold standard, which shows a narrow complex tachycardia without P waves or occasionally with retrograde P waves and abnormal axis. And treatment involves ABCs, terminating the dysrhythmia, please forgive the typo, and consulting pediatric cardiology.